Bismillahirrahmanirrahim. Bacterial infections. The bacterial infections we will talk about first, an introduction. The host defense mechanism against bacterial infection. There is the skin integrity, low pH 5.5, epidermal shedding, and bacterial flora, which either compete for nutrition or hydrolyze the lipids or sebum into free fatty acid, which has a bactericidal effect. Of course, the natural antibacterial substances in sebaceous secretion, example free fatty acids, linoleic and linoleic acid. So these host defense mechanism against bacterial infections: skin integrity, low pH, epidermal shedding, bacterial flora. And here we give an example of the not only bacterial flora but the normal resident skin flora, bacteria and others. The resident skin flora consists of staph, but not Staph aureus, Staph epidermidis, and Staph hominis, and also Micrococci B and Corynebacterium, the anaerobic, which is the Propionibacterium acne and Avidum granulosum, and the aerobic, which is the Corynebacterium minutissimum. Also, there is yeast, Candida, not in the skin but in the mouth and vagina and rectum, and the Pityrisporum ovale. So this is the normal inhabitants or flora of the skin: Staph, epidermidis, and homitis, not Staph aureus, because Staph aureus is not a normal resident of the skin flora except in anterior nerves and or perineum, and in acute lesions of atopic dermatitis. So the Staph, epidermidis, and hominis, Micrococci, Corynebacterium aerobics, Propionibacterium acnes, and Avidum granulosum, and aerobic Corynebacterium minutissimum, and the yeasts as Candida in the mouth and vagina and rectum, and Pityrisporum ovale. The first disease we will talk about is the impetigo contagiosum. The impetigo contagiosum, the definition, it is superficial contagious pyogenic skin infection, etiology staph and strep, mostly staph, especially in the developed countries, and the strep also some in the developing countries with group A beta hemolytic streptococci. The predisposing factors: hot, humid atmosphere and overcrowding, unhygienic conditions, and also debilitating skin disease, diabetes mellitus, also itchy skin conditions as insect bites, scabies, pediculosis, and atopic dermatitis. So the predisposing factors: hot, humid atmosphere, overcrowding, unhygienic measures, and itchy skin conditions. Mode of infection: either direct contact or indirect through personal belongings and flies. The clinical picture and types. We see the clinical picture and types of impetigo contagiosum. There is the classical impetigo, non-bullous impetigo. The age most common in children, site faced especially on the chin. Lesion: thin-roofed vesicles on erythematous base, which quickly ruptures, leading to eroded area, and the exudating serum dries to form a honey-colored crust. The healing occurs without scarring because it's superficial, and regional adenites could be there, and fever also may occur. So it is in the children: chin, thin vesicles on erythematous base, eroded area, honey-colored crust. Healing without scarring, regional, sometimes with plus or minus regional adenites and fever. There is the second is the circinate impetigo, either central healing with peripheral extension, gives circinate lesions, or multiple lesions that give circinate lesions. Impetigo of the scalp, the primary region of it's not the vesicle, it's only the crusted lesion, causing matting of hair, but no falling of hair. Sometimes there is nits of pediculosis and lymph nodes. The pediculosis capitis association with usually female more than male, and in the occipital region. The bullous impetigo age neonates more than neonates and infants, and usually on the trunk. And the lesion is bully rather than vesicle is the primary lesion. Bully arises on normal skin, Linsky sign negative, and it arises on a normal skin. So there is thin margins, sharply demarcated, without erythematous halo, and the bully initially clear fluid and then dark yellow turbid fluid. Bully are superficial, and within 1 to 2 days they rupture and collapse to form golden yellow crusts. MB, there is something called bullous varicella. It is superinfection by Staph aureus of varicella lesion, i.e. bullous impetigonization. The etiology of bullous impetigo is Staph aureus, phage group 2, leading to secretion of exotoxin and separation at the level of stratum granulosum. The resolution within 7 to 10 days, complications, cellulitis, lymphangitis, and bacteremia that could be complicated by septic arthritis and pneumonitis and septicemia. So there is flaccid bully, as we can see. The treatment here is, of course, antibiotics, systemic and topical antibiotics. The histopathology here in details. The epidermis split just below the stratum granulosum, forming large blisters. Sometimes neutrophils migrate through the spongiotic epidermis into the blister cavity, which may also contain staphylococci. The bacteria is there, and occasional acantholytic cells may be seen, perhaps due to neutrophils. And polymorph nuclear leukocytes migrate to upper derms, which we cannot see in the staphylococcal scalded skin syndrome. This is the impetigo contagiosum. Definition, etiology, predisposing factors, mechanism of action, and clinical types. Cercinet, classical cercinet impetigo, impetigo of the scalp, and bullous impetigo. We will see some pictures of the impetigo contagiosum. And here we can see the cercinet or bullous impetigo. The bullous impetigo again. And the crusted impetigo, sometimes it is related also to pediculosis, and there is enlarged lymph nodes. This is also a picture of bullous impetigo. The vesicles are first clear and then rapidly coalesce and form flaccid bulli. Here is another pictures of the disease. Impetigo and the bullous impetigo and the impetigo of the scalp. And there is also, this is the ecthyma. Ecthyma also is the second disease after the impetigo. You can see here that the ecthyma, thickly crusted ulcers on the leg of a patient of diabetes and renal failure. As we can see here. So this is the, you can see the ulcerated impetigo, which is the ecthyma. The second thing is the staphylococcal scalded skin syndrome. The staphylococcal scalded skin syndrome. Staphylococcal definition, staphylococcal scalded skin syndrome is a toxin-mediated epidermolytic disease characterized by erythema and widespread detachment of superficial layers of epidermis, resembling the effects of scalding. Severity ranges from localized form to bullous impetigo to generalized with excessive epidermolysis and desquamation. There is widespread detachment of superficial layers of epidermis, like sheets of erythema, after that scalding effect. Etiology and pathophysiology, it is from toxogenic strains of Staphylococcus phage group 2, toxin exfoliatin type A and B, leading to the separation at the level of stratum granulosum that bind directly here to desmoglein 1, which is the same cadherin that is the target to autoantibodies in the pemphigus foliaceus disease. So here the etiology is strains of staphylococcal toxin lead to separation at the level of stratum granulosum. The histopathology here is intraepidermal cleavage within and immediately below the stratum granulosum. Here we have inflammatory cells are absent against the bullous impetigo, leukocytic infiltration, spongiosis of the derms and epiderms. As we can see here, this is the impetigo, the bulli in the level of stratum granulosum within and the spongiotic epidermis. And you can see here also the upper part, which is the ulcerative impetigo or the ecthyma, and down is the staphylococcal scalded skin syndrome. You can see histopathology. Now we'll shift to the epidemiology. It occurs in children less than 5 years, especially neonates, due to inability of the kidney to get rid of exfoliatin and lack of specific immunity to the toxins. Sometimes it occurs in adults, but in immune-compromised patients or renal insufficiency. Clinical picture: staphylococcal scalded symptoms. The staphylococcal scalded skin syndrome originate from a focus of infection, either purulent conjunctivitis, otitis media, or occult nasopharyngeal infection, low-grade fever, and child is irritable. Lesion first, very tender, ill-defined erythema, followed by large flaccid bulli, denuded, and erosions with a red moist base. Nikolitsky sign, of course, it is positive. Gentle lateral pressure lead to shearing off of the superficial epidermis. The face first and flexural area of neck and axilla and groin, then followed by widespread within 24 hours to 48 hours. Diagnosis: skin culture is negative because it is only from the toxin, but the culture in conjunctiva and upper respiratory tract is positive. You can see the organism, which is the fourth source of infection, but the Zank smear can differentiate between the staphylococcal skin syndrome also and toxic epidermal necrolysis. Staphylococcal scalded skin syndrome, there is elongated cells with small nuclei with no inflammatory cells, and the toxic epidermal necrolysis, there is cuboidal cells and there is leukocytes and cellular debris. We will give a hint here to the toxic epidermal necrolysis, which is a severe variant of erythema multiforme with extensive detachment of epidermis in adults not responding to antibiotics. Histologically, all epidermis detaches with considerable necrosis of the cells, and the prognosis is unfavorable, increased mortality rate, and healing more than 14 days with scarring. But here, it is favorable course and only 7 to 14 days, and low mortality rate, only 3%. The treatment here is hospitalization and intravenous oxycycline, 200 milligram per kilogram per day every 4 hours, and later on we can go to home and give dicloxacillin 30 to 50 milligram per kilogram per day orally. Topical, baths or compresses, Bacterial cream, silver sulfadiazine. So healing with 7 or 14 days even without treatment. Following treatment, the denuded area takes only 3 to 5 days. Only 3% of severe infection or sepsis, the mortality rate. So this is the staphylococcal scalded skin syndrome. It's a toxin-mediated epidermolytic disease characterized by erythema and widespread detachment of superficial layer of epidermis, resembling the effect of scalding, and severity ranges from localized form, bullous impetigo, to generalized extensive epidermolysis and desquamation. The etiology is Staphylococcus phage group 2 toxin exfoliatin, leading to separation at the level of stratum granulosum. The epidemiology in children less than 5 years and in adults immunosuppression and renal insufficiency. Of course, in the children, because there is inability of the kidney to get rid of the exfoliatin and the lack of specific immunity. The clinical picture, we see staphylococcal skin syndrome form a focus of infection, purulent conjunctivitis, otitis media, occult nasopharyngeal infection. There is low-grade fever and the child is irritable. First, it is very tender, ill-defined erythema, followed by large flaccid bulli, and Nikolitsky sign positive, culture negative, and Zank smear can differentiate between it and between toxic epidermal necrolysis. The treatment is systemic antibiotics, staph for staph, first intravenous and then oral, and the prognosis is good. This is the staphylococcal skin syndrome. We can see here the stages of development of the disease. First, there is initiated by superficial, to the left, the superficial only initial manifestations of occult nasopharyngeal, conjunctival, or ear infection leading to perifacial erythema and crusting. Then there is painful edema, erythema that develops, of course, with positive Nikolsky sign, and then there is large flaccid bulli and we can see here that leads to generalized desquamation and large sheets. Of course, here we can see the histopathology of the the staphylococcal scalded skin syndrome, the generalized part to the left, and we can see down the localized lesions. Both are at the level of stratum granulosum, separation at the level of stratum granulosum, but in staphylococcal scalded syndrome there is the generalized part, there is absent in inflammatory infiltrate, but in the localized form there is inflammatory infiltrate in the form of leukocytes. The differential between the staphylococcal scalded skin syndrome and the TEN, there is, this is why Gemza stained cytology. The zinc smear can be seen with the flattened fried egg squamous cells in the staphylococcal scalded skin syndrome, and due to its superficial, and the other picture with the 10, it is you can see the cuboidal keratinocytes and together with ciliary debris and leukocytes. We can see here the leukocytes. Also for differential diagnosis, here we can see also this is the 10 lesions. Okay, it occurs mostly in adults, not in children, and it's a severe disease caused usually by many causes, mainly due to drug intake. Doesn't respond to steroid. Histologically, we said all epidermis detaches with considerable necrosis. The prognosis is unfavorable and healing more than 14 days with scarring and high mortality rate. And of course, it doesn't. It responds only to systemic steroid, not to antibiotics. Here we can see that there is the detachment. Here is in the whole epidermis, detachment of the whole epidermis, not like staphylococcal scalded skin syndrome. Again, the treatment of staphylococcal skin syndrome is usually hospitalization, intravenous antibiotic, penicillinase resistant anti-staph antibiotics, and paracetamol, fever and pain, maintain fluid and electrolyte intake, and skin care. Here we will start also the toxic shock syndrome. The toxic shock syndrome, as we can see, is it's a multi-system or multi-organ systemic illness due to exotoxin-producing strains of Staph aureus, characterized by generalized erythematous eruption, scarlatiniform eruption, and high fever. Additional elements making up the syndrome include hypotension, fever, functional abnormalities of at least 3 organ systems, and desquamation occurs in the fingertips, palmoplantar, or generalized, and scarlatiniform eruption. This is the toxic shock syndrome. We will see the pathogenesis of the toxic shock syndrome. It is mostly in menstruating women using vaginal tampons, and it is from Staph aureus toxins. Of course, the Staph aureus is isolated from the vaginal culture. There is 3 toxins. We can see the toxic shock syndrome 1, and the enterotoxin, and the exotoxin F. This is the 3 toxins of the toxic shock syndrome. So it is mostly in menstruating women using vaginal tampons. Staph aureus, 3 toxins, toxic shock syndrome 1, enterotoxin and exotoxin. Clinical manifestations: the initial hallmark is fever, hypotension or shock, diffuse maculopapular rash, The cutaneous findings as the generalized scarlatiniform erythema, petechiae, and desquamation of the palms and soles, especially fingertips, and this is 1 to 2 weeks later. There is evidence of multi-system dysfunction as muscular system myalgia, CNS toxic encephalopathy, kidney azotemia, liver, increased AST and bilirubin, blood thrombocytopenia and leukocytosis, and GIT, vomiting, diarrhea. There is death in 5% of patients. The treatment is hospitalization and treatment of shock, immediate vigorous fluid replacement, and attention is for focal streptococcal infection, drainage of an abscess or removal of tampon, etc. And there is systemic, and we give systemic antibiotic according to the culture, aimed as penicillase producing Staph aureus, as nafcillin 1 to 1.5 grams intravenous in adults every 4 hours. So this is the toxic shock syndrome. Toxic shock syndrome is a multisystemic disease due to exotoxin producing strains of Staph aureus, causing generalized erythematous eruption and high fever. There is this, the syndrome includes hypotension, fever, functional abnormalities of three system organs, desquamation following scarlatiniform eruption. Most cases not exclusively in menstruating women. The pathogenesis mostly in menstruating women using vaginal tampons. Staph aureus isolated from vaginal culture, giving rise to 3 toxic shock syndrome 1 and exotoxin and enterotoxin. And clinical manifestations. The initial hallmark is fever, hypotension, diffuse maculopapular rash, generalized scarlatiniform eruption and petechiae, and desquamation of palms and soles, especially fingertips, 1 to 2 weeks later. There is also evidence of multi-system organ dysfunction, like muscles, muscular system, CNS, kidney, liver, blood, and GIT. Death and 5%, treatment, hospitalization, and remove the source of infection, and systemic antibiotic as penicillase producing Staph aureus antibiotics. As we can see here, this is a case of toxic shock syndrome, erythema and edema of the face with conjunctival injection during the acute presentation, and this is the B residual erythema and desquamation 2 weeks after the episode of toxic shock syndrome. The second diseases are the erysipelas and the cellulites, bacterial disease, the erysipelas and cellulites. As we can see the differences between the erysipelas and the cellulites, we will talk first about the erysipelas. It is an acute infection of the skin caused by group A beta hemolytic streptococci involving superficial derms and lymphatic, characterized by erythematous sharply demarcated lesion. The organisms gains entry through minor abrasion, ingrown nail, minor abrasion. Lesions are well demarcated, erythematous, fiery red edematous, and which is hot and tender swelling. The edge is well demarcated, raised edge, advanced edge. The site, usually the face and lower limbs, most common sites, and usually unilateral but maybe bilateral. And symptoms onset usually preceded by prodromal symptoms of malaise, fever, etc., and may accompanied by constitutional symptoms as chills, fever, and headache, vomiting, joint pain. Leukocytosis more than 2,000 per cubic millimeter, and there is plus or minus lymph nodes. Healing may occur by desquamation, bully, or hemorrhagic necrosis. Desquamation, bully, or hemorrhagic necrosis. The complication recurrence usually leads to lymphatic obstruction and leads to chronic lymphedema and post-streptococcal glomerulonephritis, because here it is by group B, beta hemolytic streptococci, so the complication could be post-streptococcal glomerulonephritis. The treatment is penicillin, and also we can give augmentin or inosine orally. Okay, this is the erysipelas, which is acute infection of the skin caused by beta hemolytic streptococci in the superficial derms and lymphatics, and it's sharply demarcated. The cellulitis is acute spreading infection of deep dermal and subcutaneous tissue caused by staph usually, and sometimes strep or H. influenza or mixed infection, characterized by localized pain, tenderness, erythema, and warmth, differentiated from erysipelas by lack of distinct margin between the affected and normal skin. Usually here also the extremities and the face, and symptoms, constitutional symptoms, fever, etc. Leukocytosis may be present, draining lymph nodes may be pulpal and tender usually, and healing may occur by desquamation, polyhemorrhagic necrosis. The complication here is recurrent cellulitis only, leading to chronic lymphedema. Here there is a differential diagnosis of deep venous thrombosis. So the treatment is initial empiric therapy for both staph and streptococcal, usually penicillins, intravenous penicillin-resistant penicillins, or first-generation cephalosporins, and the rest and analgesics. So the differences here, we can see the erysipelas is staph, mainly strep, and cellulitis mainly staph. The erysipelas is in superficial derms and lymphatics, the cellulitis in deep derms and in subcutaneous fat. And the erysipelas is well demarcated, the cellulitis is not well demarcated. Both have constitutional symptoms, and healing occurs with desquamation, poly, and hemorrhagic necrosis. The complications are mostly, both of them leads to lymphatic obstruction and lymphedema, but we add to the erysipelas the post-streptococcal glomerulonephritis, and also there is differential in the cellulitis we added, which is the deep venous thrombosis. We should send him for Doppler if we suspect, and especially if there is pain with dorsiflexion, if it is in the leg, and both we give penicillin or first-generation cephalosporins, which covers both. As we can see here, this is the pictures of both. To the left is erysipelas. You can see the erysipelas well demarcated. Here we can see painful edematous erythema with sharp demarcation on the cheeks and nose. Here we see also it is well demarcated, fire red erythema and edema. Here we can see in cellulitis it is not well demarcated, swollen erythematous and tender, and we can see the site of surgical excision and the discharging pus. The streptococcal intertrigo, it is longitudinal painful fissure with red, moist, and even crusted skin around. The site is under the breast, groin, and behind the ears. Differential diagnosis from other causes of inguinal regions, and we can see it here, the intertrigo. And there is a note also on the ecthyma here. We can see it is ulcers of the leg covered with dirty brown crust and saucer-shaped shallow ulcer. And the treatment is systemic antibiotics and local antibiotics. It's in the upper derms.